Hello, everybody out there in the Western Virginia EMS region. This is the 2019 protocol rollout. My name is Dr. Eric Stanley, and I am joined by
Dr. Allison LaPera
and Dr. Brian Eakey.
It's good to have you all here. We're excited to finally get these protocols out to you. We know they've been a long time coming, and we thank everybody for their patience.
So there are going to be some things that we cover that apply to everybody, and then a few ALS-specific things a little bit later on that we'll discuss.
Yeah, but I think in general, all of the information in this rollout is going to be helpful for all providers, even if little parts of it don't apply to you. So hopefully you'll enjoy it. All right, so I think, as we get into this new document that we have created, I think it's important to look at kind of where we've been.
So when we look at the old protocols, that was a really good document we used for a really long time. But the more that we tried to use it and the more we were coming with new protocols, we realized there were some really big areas we could improve. Some of the things with the current protocols we noticed is they weren't really formatted for screens. So it was difficult to use electronically. More specifically, too, there was just so much complexity included in each protocol that it was difficult to use during a call. They were, super rigid instructions that led to some confusion when you tried to follow that in the heat of the moment.
Yeah, and I think when you look at the 2015 protocols, the kind of the current version that we're under, they really do represent a quantum leap from where we were even before that. So anyone that was practicing in this area in the late 1990s into the early 2000s remembers the dot matrix of death.
Oh, yeah. Oh, those old pink pages were fantastic. And certainly the 2015 update was a vast improvement over that. But I think there's even some more area that we can improve, and that's what we were looking for.
All right, so let's get into it and take a look at the new document.
Yes, one of the things we really tried to do here is make it accessible during a call. Several ways we did that is to format it specifically for your phone. It's distributed electronically in the app stores. It's got an interactive table of contents with quick links. And then really it also comes down to some of the concepts also. We tried to make it simple enough and easy enough and streamlined enough that you could use it during a call.
So, but what about, for an old guy like me, can I still print it?
Yeah, so it does actually still come as paper. You can download the PDF. It does make a nice little book.
Yeah, so one of the changes that you're going to notice is that each protocol is now 2 pages. So one of the pages is going to be like a detail side. It's got a lot of the specifics, some of the nuances, and really it's more designed to read en route. And the other page is going to be the algorithm side. And this is maybe what you would reference during a call. It's much more streamlined, sort of the action side of the protocol, if you will.
Yeah, and we did this on purpose, trying to make it more accessible during the call. So while you're in the middle of actually running a call, you got a patient in front of you, you can refer to that algorithm side. But if there was something specific you couldn't remember, then you do have the details right next to it. And every protocol is laid out this way. They're all exact same format, so you'll never be searching for information.
So now this kind of brings us to what I consider to be the most important page in the entire protocols, and that's the how to use section.
Right. So this is really where we get into it. Our attempts to simplify the protocols gave us a few good ways to cut out a lot of repetition, but it really meant that we had to restructure the way that we use protocols. So in other words, we're not going to include oxygen in every single protocol where we think oxygen is appropriate. We just wrote one oxygen protocol, and we expect people to know to go and use that. What that means is the old protocols were more like a recipe in a cookbook. You went to the one you wanted, and that had everything that you needed, whereas these are more like tools in a toolbox. So we expect you to be using multiple ones at the same time, to blend them fluidly, and know which one takes precedence, so to be able to jump from one to the other.
So everything that's marked either at your level or below, you can use in this toolbox.
Another thing we did to try and simplify the protocols is not repeat all the basics.
So things like scene safety, BSI, ABCs, calling for ALS, notifying the emergency department, all of these things that we do on almost every call, we just assume that you are going to do.
Yeah, we don't expect to have to tell you to wear gloves.
Yeah, these are things that have been beaten into you since your first day running a call. So we know that you know these things.
Okay, let's see how this works in practice. So for an example, say we're responding to a 52-year-old male with chest pain.
So on the way to the call, or even as you get the call, you'd want to sort of be thinking in your head which tools in your toolbox you want to use. This isn't like a cookbook like it used to be. You're not just going to turn to one page. You need to be determining which of these you want to use together.
Yeah, and remember, like I said, we're going to assume the basics. So you're not going to find at the top of that protocol, scene safe, BSI, call for ALS. These are all things that we know that you can do.
Absolutely. So you decide you're going to a chest pain call. turn to the chest pain protocol. On the way, this would be a great time to look at the detail side. This is going to have a lot of the nuance, a lot of the specifics, a good time to brush up on exactly what you need to accomplish when treating chest pain.
But the chest pain protocol is probably not the only protocol you're going to be looking at.
For sure, right? Because then if you start using the algorithm side during the call, you'll notice that it really only has the chest pain specific stuff. There's no mention of oxygen, no mention of pain control. We would expect you to understand to go to those protocols if you needed them.
Okay, so the next thing that I think is important to remember and how to use this document is that you can call for online medical direction anytime you need advice.
Yeah, we've gotten a lot of feedback on these protocols, and one of the most important things for everybody to remember is even though these represent the basics and the fundamentals, that doesn't mean you can't call for permission to do something else. So if you run out of medicine or you want to try something that's not specifically included here, you always have the ability to call and ask.
And if you can't get in touch with the hospital or with medical direction, do the right thing. And remember, it's about getting the patient to the hospital.
Another consequence of us trying to really simplify these protocols is we're really relying on you guys and relying on your training. Dr. Stanley, perhaps you could talk to us about can you versus should you?
Yeah, well, that's a great topic. So, we wanted to give you a lot more flexibility in these protocols. But, just because you can do something, because a skill is listed in the protocol, it doesn't mean that you should do that. And in fact, any actions that you take in these protocols, you're going to need to be able to defend your reasoning. Doesn't mean that you're under the magnifying glass or in the skillet, but you might be asked why you chose to do that. So it's important to make sure that you're acting in good faith and relying on your training when you make these decisions.
Yeah, we're trying not to make this a textbook. These are the tools that you are authorized to use. We're not telling you necessarily how, when, or why. We expect that to come from class and continuing education. This is more of a authorization to do these without having to ask.
Exactly. And that kind of goes back to that cookbook analogy. So just because things are listed doesn't mean you have to do everything that's listed in the protocol if you don't feel it's indicated.
But I do like that the order kind of suggests the importance, but it's not really absolute. You're still using your judgment.
Yeah, skip around. If you think that it's more important to do things in a different order, that's a decision that you, as the caregiver, get to make and something that, you may be asked to explain later.
Including in that, you don't even have to do necessarily everything that's in the protocol. It's just those are the things that are allowed if you think they're necessary.
Yeah, at the end of the day, do what you think is right for the patient and provide just enough care to get them to the hospital. Okay, so let's look at another example in the vein of can you versus should you? And for that, let's look at an example of an allergic reaction.
So we'll say you have a 32-year-old male. He has an allergy to latex, and he's calling EMS because he has some hives on his hands and thinks he's having an allergic reaction. So you've pulled up your allergic reaction protocol on the way to the call. And tell me, Dr. Ike, what do you pull out of that protocol that's important to complete?
Right, so you look at it there, and you've got several options, including albuterol, Atrovent, and Benadryl. But if the guy just has hives on his hands, then we trust you guys to understand that albuterol and Atrovent probably aren't going to help him a whole lot. So in this case, we'd certainly suggest that you would skip the albuterol and the Atrovent. And honestly, if you're right next to the hospital and it's a mild reaction, you may just skip the Benadryl altogether. But they're all there, and if you think that he's starting to have some trouble breathing or something like that, then absolutely give the albuterol and the Atrovent. The point here, though, is that we're relying on your training to decide which of these things is appropriate and which is appropriate to skip. So this brings us to perhaps the most critical new concept in the entire book. When we tried to simplify these down, we recognized that there was an awful lot of decision points, so we tried to condense them into a concept called severity.
For severity to work, we really rely on your training and your judgment of the patient that you see in front of you.
Right. We're going to have a bunch of text that comes along in each protocols. Those decision boxes will be listed there. They will help you out with, our opinion on what would make something more severe or less severe. But what it comes down to is provider judgment.
And one of the critical things to remember about severity is that it's dynamic. It changes throughout the call. So your patient may be getting better. Your patient may be getting sicker. So it might be really important to reassess and restart each protocol depending on what you see in front of you.
One of the super critical things with severity is to understand that even though it is subjective, sometimes it's rather specific. So let's take a look at an example.
A particular example, say a minor motor vehicle collision. If you're looking at discomfort, there's this decision point on severity. Is this mild, moderate, or severe? And that's where your judgment comes in to make an appropriate decision. Is fentanyl appropriate in this case?
Yeah, so when you're talking about pain, it gets complicated, right? Because the severity is pretty subjective. When you're looking at the patient, they may find their pain to be really, really severe, and you as the provider may think it's more moderate. So this is where you have to use that provider judgment to decide exactly how much of the protocol you need to use for this particular patient.
So if you're looking at the pain protocol, you'll notice that it does have some text there to help guide you. It talks about vital sign changes and how distressed the patient is. So in a case like this, if they've got normal vital signs, but they're saying that they're kind of upset about it, I mean, you could make an argument for moderate pain, but I don't think here, that anyone would agree that ketamine is appropriate. Certainly Tylenol would be fine. And then it's up to you as a provider to decide whether or not you think fentanyl is appropriate.
So that's a great example of where it's a little bit more provider dependent, but there are several examples in the protocols where it's pretty cut and dry. It's pretty objective, right?
Absolutely. So one of the good examples of it being very cut and dry and very black and white would say be the spinal immobilization, or the new term.
The what now?
Yeah, the new term would be spinal motion restriction, which we'll get to a little later. In this protocol, you have clear indications for when you should do C-spine, and if you have any of those, there's really no room for judgment here. Clearly, if they have spine tenderness, such as in this example, they would require immobilization.
So much in the same way that we assume the basics for every call, there are some routine care things that we assume for every call as well.
Yeah, and this is more along the lines of trying to simplify and streamline the protocols. We're not going to mention every single time where we think that a glucometer would be necessary, or an IV, or a 12-lead, or something like that. The protocols may include reminders, but just like everything else, you do what you think is right. And even if it doesn't include something, say like 12-lead, if you want to do one because you think it's the right thing to do, then we would support that.
There are also some basic first aid things that you can just assume and use your judgment for.
Sure, yeah, we're not going to tell people to put Band-Aids on.
Yeah, now there will be some specific protocols that have a reminder, and these are cases when we think that it is particularly important or maybe even particularly easy to forget.
Yeah, I think everybody's probably forgotten at least once to do a glucose on somebody that's had a little altered LOC, so it's definitely in there.
The other thing to notice, there aren't any PED-specific protocols. No longer do you have to flip to a specific PED section.
Yeah, I think this is actually a really neat functionality of this document, is that anytime you have a pediatric patient, you're just going to go to the protocol that you would go to like normal, because every protocol is a pediatric protocol.
And one of the things we really worked hard on are ages. So over the course of the years, all different agencies, we've always struggled with what age is an adult, what age is a child, what age is an infant. And we came up with some guidelines that we're going to stick to throughout this protocol book.
Yeah, so for this book, we agree that legally an adult is 18. But the point here is that any child 13 years of age and older is technically a child legally, but in general, in the pre-hospital environment, is safe to be treated as an adult.
So 13 years and older, that's treated like an adult in the protocols.
Right. And anybody 12 and younger, you should look specifically at the pediatric section of every protocol for any deviations or special notes about it.
The other thing I really like is that there's a completely separate appendix with custom dosing for just our medicines that are in our drug boxes.
Right. So, if you look at the standard length-based color tape, which is not a trademarked phrase.
Not a trademark phrase.
Not a trademarked phrase. You'll notice that a lot of those drug dosages are for things that we don't even carry, and even some of them that we do carry, they're resuscitation doses, not standard doses. So you have to be really careful with your standard length-based color tape. So what we've done is we've created a custom one in the back that has every single drug you'll ever run into, and it's laid out very much the same, and the colors also match.
Wow, isn't that ironic?
So finishing up our how to use page are the references. We wanted to make sure that everybody saw where we got these ideas from and was able to cross-reference them and look at them outside of this protocol book.
Yeah, and another thing that we struggled with is brand name versus generic names. And there are times in the book where you're going to see those two things switch. And a lot of that, honestly, is for formatting.
And don't forget, we're mandated reporters for abuse. So if you come across a situation where you're suspicious of child or elderly abuse, it needs to be reported.
And despite what I would like to believe, we are not perfect and neither are these protocols. So if you think you find an error, please reach out to us and let us know.
All right, so we've talked about the new protocols and why we formatted them the way we did. We've also talked about how to use them. So let's put that all together. So if you pull up one of the protocols there in your app, or if you're looking at it on paper, let's go over to the detail side and really get down to the details that are included there. You'll notice right at the very top, the first thing is a line that's called also called. So, each protocol we have has multiple names. If you're looking, say, at the chest pain protocol, that could be like the MI protocol or the heart attack protocol. The point is that they're all the same.
Yeah, and the next thing you're going to find down is a list of imperatives. Now, we've been talking a lot about how to use this protocol and trust it in your training, but there are certain things that we expect you to complete for every call and that we expect are done, and that's where you're going to find those things is in the imperatives section.
And then the next section is about medication. So some of the details about different medications, some different contraindications for the medicines are all listed kind of on that detail side to review.
Sure. And especially for some of the bigger protocols like allergic reaction, not every single medicine is necessarily listed there. That's really only if there's specific details or other important information to know about that medicine.
Another thing I like is that you have these little badges.
Yeah, and you'll see those badges a lot of places. They're on stroke alert, they're on trauma alert. There's several places where there's little breakout boxes on the detail side that'll give you information about a specific kind of concept, say like a poor perfusion, or it'll remind you what the VAN stroke scale is all about, which we'll talk about more in a minute.
And the next thing you're going to see down on that list is the notes side. The notes section are details that don't really rise to the level of imperative, but are sort of those finesse details that can really aid you in the care of a patient, but aren't necessarily required.
And then we get back to the pink section again, where our pediatric specific kind of notes are included. So any sort of details that are important to remember for children are going to be listed in the pediatric section.
Next down would be the references. Again, these are all linked, so you could check it out if you had internet access. It's a lot of online articles. It also will reference the appropriate chapter in Brady's Emergency Care.
And there's also some interesting information embedded in the protocol, actually. If you want to know the last time a protocol was revised, you can find that on the perimeter. You can also find the NMSIS data on there as well.
So now let's take a more detailed look at the algorithm side. You notice right at the very top, it starts with an indication. If you did not meet this indication, you would need to have a significant explanation as to why you used any of the interventions in this protocol. Next down is that big severity question. So that's going to be the one that really requires provider's judgment. It's included in just about every protocol and is the crux of the entire new format.
And I think you'll notice kind of the shape and the color are consistent throughout the protocol. So any of those decision points are going to be kind of that diamond.
Underneath the decision, you're going to get those decision text boxes. That's going to aid you in your decision as to whether or not you think something is really bad or not quite so bad. And then underneath each one would then be the indications that we think are appropriate for that level.
And as you get to the bottom of the protocol, you're going to see that there's a considerations box. So as we mentioned before, these are tools in a toolbox, and this is a place that can lead you to some of those other tools.
And then a few special protocols, you'll notice kind of that consider destination triage. So STEMI, stroke, trauma, all of those have specific destination considerations.
Yeah, and we'll talk a little bit more about destination triage later. And there are some other badges. As you flip through the protocols, you'll notice some of them mention, make sure that, the patient is deconned. You don't want to, get the crew contaminated or something like that.
And then at the very bottom, you're going to find a list of medications that are listed in the protocol and their relevant doses.
So you've been introduced to the new protocols. Let's take a look at the new drugs. Not all of these may apply at your level, but it may be useful information.
All right, so the first drug that we'll talk about is D10, and D10 is going to replace D50 in the drug box. You're going to find that D10 is a lot easier to give, so it's a drip instead of a large bolus, and one of the good things about it is a lot less sclerotic to patients' veins. So pushing in D50 can blow a vein, it can even scar a vein down permanently. And D10 is also going to give you less of a sugar spike and a more consistent glucose load to wake up those hypoglycemic patients.
Yeah, it's also physically a lot easier to push. It's not as sticky as D50.
Yeah, and this is one of those drugs that you may see in different packaging in the drug box because it's available through a lot of different providers.
Yeah, but all D10 is the same concentration, so the drip rate is going to be the same no matter sort of how it's packaged, how big the bag is.
Exactly.
All right, next up we have Atrovent and Decadron that you'll find kind of in both the dyspnea and the allergy protocols. Atrovent really complements albuterol. If you heard of a duo-neb, it is the other part along with the albuterol. And Decadron has some advantages over solumedrol. So you'll notice Decadron's replacing solumedrol. You can give it either IV or PO.
Yeah, it's pretty much just a one-to-one replacement. Decadron PO is also the same exact medicine. So you literally draw it up out of the vial, you squirt it into something that tastes better than just pure Decadron, say like orange juice, and then you can have like a young child drink it instead of giving it IV.
Yeah, and this is one of those medications that gives us a lot of flexibility going forward to do new and interesting things with some other protocols. So stay tuned for some of that.
Next up is one of the most exciting additions, and that's ketamine. So you've probably heard a lot about it or heard other people talking about it. Ketamine is a powerful and useful drug. It's a dissociative anesthetic and can do a lot of different things. In this version of the protocols, we're using it primarily for pain control, so that would be low dosing. Also for mild sedation in ROSC. Ketamine, as I'm sure you're aware or have read or heard about, can also do an excited delirium or take care of excited delirium, but we're not quite rolling that out.
Yeah, and one of the things you're going to need to know about ketamine is there are some potential side effects, and some of them are going to be expected side effects. One of the things that providers are going to notice right away is that when you give ketamine, rarely, if ever, will patients close their eyes. So
but it can be really disconcerting.
Yeah, their eyes are going to be open, but the lights won't be on. You can also get a lot of kind of roving eye motion. That's normal. There's also some nausea and vomiting that can be associated with ketamine if it's pushed too fast. But if you give a slow push with ketamine, you should really reduce the risk of nausea and vomiting.
Always a good idea to let family members know about the expected nystagmus and eye movements, because they really are kind of disconcerting to see for the first time.
Yeah, and ketamine is an interesting drug in that it has a couple of therapeutic dose ranges. So low dose ketamine is really quite good for pain. Medium dose ketamine is quite good for hallucinating. So that is what people tend to call the K-hole. And high dose ketamine is an induction drug. So you can really knock someone out and completely out of consciousness with it. So we want to avoid that middle dose.
We're going for the lower, mild sedation and pain control with the ketamine.
Yeah, and ketamine's also going to have a positive effect on your cardiac output. So it's going to cause tachycardia. It's going to cause hypertension in some settings. Those might be actually desired outcomes. In some settings, they may not be. It can, in rare cases, cause laryngospasm. Again, if pushed slowly and carefully, that should be less of a concern.
So our next medication is labetalol, and this is going to be our medication that we go to for hypertensive emergency or hypertensive urgency. Now, it's a beta blocker, so there are some things that you want to avoid giving labetalol. So some of our contraindications really are patients with asthma. If their heart rate is already under 60, this is going to cause some additional bradycardia, so you'd want to avoid it in those situations, and in patients with a heart block. And also really are only aiming for about a 20% reduction in the blood pressure, and that's systolic blood pressure. So we don't need to be giving this for patients that already have a blood pressure under 190.
Another new exciting drug is TXA, or tranexamic acid. This is one that's been used by the military an awful lot and is now making its way into civilian medicine. Its primary mechanism is that it blocks the body from breaking down clots. So if you have big trauma, big bleeding, big exterior blood loss, this is a great medicine to give to help the body continue to clot and hopefully not lose all that blood. There's several other indications for it, but at least in this version of the protocols, what we're going to use it for is massive external bleeding. And one of the best parts is it has very few side effects.
So you mean even if I have a large epistaxis or nosebleed?
Yeah, so you'll find literature out there for TXA for nosebleeds, but at least in this protocol, in this version of the protocols, what we're concentrating on is major external traumatic blood loss.
Yeah, and TXA is coming in at the A level. And TXA is an interesting drug in that it's a little bit time sensitive. So if you're considering giving TXA, it needs to be given upfront as quickly as possible.
All right, so we've finished up with the difference between the new and the old protocols. We've finished up with how we expect providers to utilize this new book. We've gone over some of the new drugs. Now let's talk about the new medicine.
One important concept with this protocol book is that these protocols represent the basics. They represent a place to start. They are a standard for everyone to practice at in the region. And it's important to remember that your OMD can add specific protocols for your agency. For example, intubation. If you want to run an intubation program at your agency, your OMD can elect to add that to these protocols. But really, the ones that are in this book are meant to be foundational, a place for everyone to start, and a standard of care to be established.
So one of the new medical updates is going to be for cardiac arrest. This is something we're pretty proud of, that we took all of the nearly dozen cardiac arrest and traumatic arrest protocols, and we condensed them into two. So if you take a look at the medical code or the trauma code, you'll notice that every cardiac arrest algorithm is included in that one page.
So there's no longer a VFib, a VTAC, an asystole, a PEA page. It's all condensed onto this one page.
We really focus on teamwork and this pit crew idea of CPR, which really mirrors the American Heart Association emphasis on compression. So you've got a specific person doing compressions, you have somebody set up for AED, and somebody else that is working on the rest.
Right. And they're really concentrating on just their job. So if you're assigned to be the compressor, then the only thing you're really concentrating on is making sure you're doing hard, fast, good compressions and minimizing the breaks, because we all want to make sure we're updating to the current standard, which would be compressions as the most important thing, even over top of airway and breathing.
And if pit crew is new to you or new to your agency, we've included a link down below in the description so you can get more information on that.
Some of the other things you'll notice in the cardiac arrest algorithms do go along, are aligned with the newer science that's coming out for pre-hospital resuscitation. Two specifics there would be we're moving away from amio. The science really has not borne out that amio is any necessarily better than lidocaine. And lidocaine maybe is a little bit more streamlined to give, a little bit easier to give, but amio is still in there. So if you have a specific case or you have a specific reason that you're giving amio, then that's fine. But our go-to drug is going to be lidocaine.
The other thing you'll notice is giving meds by IO. So an intraosseous needle is going to be kind of a faster way to establish access. So there's no wasting time kind of trying to find an IV. You go straight to IO.
Yeah, we're specifically recommending against IVs in a code. Now, if you get ROSC, then sure, you can take time to get an IV, get en route, that sort of thing. But specifically for arrest, if you need to get access, we're recommending head straight to IO, skip the IV.
And in the past, we didn't have a specific trauma code protocol. We do now in this set, and I think you're going to find that useful. And we've also made a specific return of spontaneous circulation protocol. So hopefully you'll be successful in your resuscitation. And if you are, we have a protocol to direct you to as well.
Yeah, same thing. There's one for trauma. So there's a med code and a med ROSC, and there's a trauma code and a trauma ROSC. And obviously the pediatric protocols for all of that are included in those protocols.
And cardiac arrest and resuscitation in general is a topic that is very broad, and there's a lot of details to get into. And obviously, you can't fit all of those details in a single protocol. So this is one of those areas where you're going to have to stay on top of your certifications and keep up with your continuing education.
Yeah, it's a balance between trying to simplify it so much that you can use it, but not oversimplify it to the point where it's not useful at all. So we hope this strikes the right balance. This is something you could use in the middle of a code, help remind you of which drugs are important, what their dosages are, et cetera, but it's not overly complicated.
So one of the other things we wanted to talk about was epinephrine. So in particular, we bring in the concept of an epi drip. Now, this isn't a new medicine for you. You're used to using epi, but we're going to give it kind of a new route and a new way to kind of draw that up. So to make an epi drip, you're going to take 1 milligram of epinephrine and a liter bag of fluid, so a liter bag of normal saline. For adults, you would use the macro drip set. Peds, you would use a micro drip set. And then really you're able to kind of titrate using that based on the blood pressure and those kind of markers of severity. So you can start around 1 drip a second and either go up or down based on kind of the results and the response the patient has.
All right, so the next thing to talk about is the stroke protocol. There have been some significant changes to the way that we are approaching stroke in the region.
Right. It's not so much the treatment of stroke, right? Because pre-hospital stroke treatment is basically just go to the hospital, the most appropriate hospital, as fast as you can. Not a lot of pre-hospital interventions for stroke specifically. But what we have recognized is that stroke treatment is evolving quickly. So just like, heart attacks now are sort of separated out into big STEMI heart attacks versus little non-STEMI heart attacks, and we recognize that triage to a bigger center can really help those STEMIs, the same is true for stroke. And so we do have a few stroke hospitals in the region that can deliver that higher level of stroke care. So if we have a little stroke or a VAN negative stroke or a stroke that we do not think is a large vessel occlusion, those kind of strokes would be appropriate to go to pretty much the closest facility, wherever we're going to go.
Yeah, I think what you're saying is what it boils down to for EMS is the most important part for us is being able to recognize a big stroke from a small stroke. And the way that we're going to continue to do that is to continue to use FAST as our primary screening tool.
Right, the Cincinnati Stroke Scale, yep.
And if we have a positive FAST, we're going to move on to VAN. And VAN is a little bit of a new screening tool for us.
And really, that's designed to help us look for those large vessel occlusions that can be better treated at a comprehensive stroke center.
Yeah, so if you're FAST positive and VAN positive, you probably need to go to a center that is equipped to deal with a large vessel occlusion in the brain.
Right. So that would be triage, then past a smaller hospital to a larger hospital. And we're going to get a little bit more into detail about destination triage here in just a moment.
Stroke is one of these areas where things are evolving quickly. So, right now we are using fast and van, but that may be subject to change in the future as things rapidly evolve.
So the next thing to talk about would be spinal motion restriction. You probably recognize this as immobilization or spinal clearance or C-spine. It's actually pretty simple now because most of the major players in the areas of pre-hospital trauma all came together, wrote a big paper in 2018. So we went back and we modified our immobilization protocol to reflect that paper. The paper is linked there in your references if anybody wants to read it. But the big takeaways is the name is now spinal motion restriction, even though it's a similar concept to what you're used to.
And really, there are 6 indications for spinal motion restriction. And I know we've talked about severity in a lot of different parts of the protocols, but these are really just yes or no. They're either present or absent, and there's really not a middle ground for these.
Yeah, so in the case that one of these indications is present, it's pretty straightforward. Do spinal motion restriction with a C-collar. Now, what do you do with the rest of the spine?
So that's where the new paper actually helps us out a lot. It says that spinal motion restriction requires a rigid C-collar and requires supine positioning. But the new thing here is they say the ambulance cot is just as good, if not better, than a backboard.
But you use some of these adjuncts to move people back and forth.
Right, for sure. So the new paper states that if you suspect spinal injury and you have an indication for spinal motion restriction, SMR, you should hold C-spine just like you're used to. You should apply a C-collar just like you're used to. You should use an adjunct to get the patient on the cot. But once they're on the cot, if the adjunct is easily removable, say like a scoop stretcher, then you can get rid of it. So you could take the scoop stretcher off and just have a immobilized, quote unquote, patient on the cot with a C-collar and seat belts. And that's it.
Yep. Now, one of the important things that you're going to have to think about is as you arrive at the hospital, you should have a plan for how you're going to transfer that patient to their hospital stretcher, and everyone should be on board with that plan.
Yeah, and the paper's pretty clear about this. Asking them to move over is not okay. Sliding them without an adjunct is not okay. But if you have one of those like slider boards at the hospital, or you've got enough people to manage with a sheet, et cetera, et cetera. And another interesting point here is even though you've taken manual C-spine, you put the collar on, once they're on the cot, if they're awake and they can follow directions and they can hold their head still, you can release manual C-spine. So that would be a patient belted in the cot, no other immobilization other than the C-collar, and you tell them, hey, please don't move your head. We're worried about your neck.
This is an important protocol to get very familiar with. So spend some time looking at the imperatives and realize that these are not things that we invented. These are things lifted directly from that paper that we referenced earlier. And spend some time looking at the notes section of this as well. This is going to generate a lot of questions for you and your agency. And I encourage you to speak to your specific medical director about how you're going to address some of these concerns that may arise. All right, so next up is termination of resuscitation, and this is a complex topic.
It sure is. We went through an awful lot of revisions trying to get this correct. We split it up into 2 basic groups. The first one is easy. It's withholding resuscitation, right? So if a patient has a DNR or a post, those are 2 things you guys should be familiar with, stating their wishes. It's signed by a doctor, has an emergency phone number. You should absolutely honor those things. And even if it's not immediately available, you can start CPR until the family or the nursing home or something is able to produce it. Once they find it, produce it, you verify it, then you can stop. That's not terminating resuscitation. That's just withholding it. The other time it'd be appropriate to withhold resuscitation is if there's obvious death or mortal injury. And those are the things that would be listed as absolute contraindications to resuscitation in the medical code and the trauma code section.
So if we're actually going to talk about the specifics of termination of resuscitation, the first thing we need to do is identify a patient population that can be included. And there's some special cases that absolutely cannot be included in termination. Right.
So these are the kind of patients where, it's inherently obvious to any seasoned EMS provider, this is not a patient that you should work in the field and then call in the field. We're talking about like little kids that fall through the ice or lightning strikes or poisonings. These are people that really would benefit from things that are not found in the ambulance, from procedures or medications or equipment that is just not available pre-hospital. So any special case, regardless of ALS or BLS, regardless of anything else, if they don't meet criteria for withholding, if they're a special case, you should prioritize transport.
And then there's some difference between ALS termination and BLS termination. So with ALS providers, they're really going to be attempting their resuscitation on scene. They call medical control if no ROSC there within 30 minutes. And they're not one of the special cases that Dr. Icky just mentioned.
Absolutely. So this gets really sticky because there are many, many papers on ALS versus BLS termination. And to really get into it, you have to actually look beyond just the recommendations and the conclusions of the paper. You actually have to get down into the details where they talk about the special cases. They talk about the time frames and things like that. The best consensus that we could find was 30 minutes for a standard ACLS run resuscitation that is not one of those special cases. So that would be your ALS termination rule is try full ACLS for 30 minutes. If you do not get ROSC, then call medical control for field termination.
All right, and lastly, let's talk a little bit about BLS termination. I think it's kind of interesting when you look at the ALS versus BLS termination. You would think BLS would be simpler, but that's not really the way it plays out. There's a lot more caveats.
Right. So this is where it gets a little tough, right? So as a BLS provider, you're not able to provide that full ACLS type of resuscitation. So if ACLS resuscitation is not available, then BLS resuscitation becomes futile after about 15 minutes, but there are some notable exceptions. The most important thing to recognize is if you are a BLS crew, your number one priority is to try and get ALS. So if you can get ALS on scene within 15 minutes, do that. If you're within 15 minutes of a hospital, do that. But your entire goal is to try and get the patient to that ACLS level of resuscitation. If that's not available in the first 15 minutes, then there are some caveats where prolonged resuscitation, even prolonged BLS resuscitation, even after 15 minutes would still be appropriate. And the big times there is if the EMS provider witnesses the arrest, that person should always be transported. If they are ever shocked by the AED, that patient should always be transported. And then obviously, if you get ROSC at any time, that patient should be transported.
Yeah, and resuscitation, much like stroke, is an area where things are evolving rapidly. Currently, we do not have a program to put patients on ECMO, but if that were to be started in our region, that would change this whole paradigm on its head. So stay tuned for further updates. Okay, so destination triage. We alluded to this a little bit earlier when we talked about stroke, but let's jump into the weeds now.
So destination triage is really going to be for our STEMI, our large CVA, so if we're concerned for like a large vessel occlusion, and then for trauma.
Yeah, so the region has triage protocols for these conditions. We're just trying to reemphasize them here and codify it, make it a little bit simpler. So the magic number here is also 30 minutes. So if you identify a big heart attack, known as a STEMI, a big stroke, known as a large vessel occlusion, or major big trauma, we would encourage you to bypass a smaller local hospital to get to a bigger, more capable hospital. And then, like I said, the 30 minutes is the key there. If you can get to that bigger hospital while adding less than 30 minutes to your transport time, do that. If the bigger hospital is going to add more than 30 minutes, we would suggest you go to your local hospital, let them stabilize, and then arrange from transport from there.
And this is the time to think about air transport as well, and to think about those type of transport times.
Right. If you're out in the middle of nowhere, we would encourage you to be calling for aeromedical transport for large vessel stroke, for STEMI, and for major trauma.
All right. Congratulations. You've made it to the end.
We appreciate your time and appreciate you watching our video. Down in the description below, you'll notice that there's several links that we've mentioned. There'll be a link to the pit crew CPR concept. We encourage you to review that. There'll be links for each of the new drugs that we went over today, including also the epinephrine drip. But then the most important thing is the link to the protocol rollout quiz. So this is something that we want you to review this video, review the new protocols, and then go and take the quiz. It's open book. You take it as many times as you need to until you get 100%. Once you do get 100%, print that off and turn it into your training officer. Your training officer will be in charge of releasing you to use these new protocols.
Yeah, so this is a document that we've put a lot of time into and we're really proud of. So we're interested in your feedback and we hope you enjoy using it.